So next we will move on to an topic, the endocrinology of tuberculosis by Dr. Sridhar Subbiah sir. So may I request Dr. Sridhar Subbiah sir on the stage.
Introduce Dr. Sridhar Subbiah, who is going to talk on the endocrinology of tuberculosis. The tuberculosis commonly affects the adrenal gland, and now the thyroid gland is also one of the gland commonly affected by tuberculosis. Now the speaker is Dr. Sridhar Subbiah is going to enlighten us about the tuberculosis infection, which is common in India, and the endocrine infections of tuberculosis. Thank you,
Good
sir.
evening, one and all. At the outset, I would like to thank the chairpersons as well as Dr. Prem Kumar for giving me this opportunity. So, I will be discussing in the following headings: tuberculosis versus extrapulmonary tuberculosis, and what are the immunoendocrine alterations that is happening in tuberculosis, and what are the endocrine systems being affected in tuberculosis, and diagnosis, and the interference between the anti-tuberculous therapy and various endocrine systems. So, as you all know that the common route of spread is droplet infections, and the high-risk groups are elderly, diabetic individuals, alcoholism, HIV, and illicit drug users. So, the prevalence of tuberculosis is increasing, and uncontrolled diabetes, the reason again is increasing. And as you all know that there are various extrapulmonary lesions of tuberculosis. Among that, most common known is scrofula, that is lymphadenopathy, tuberculous lymphadenopathy, and subsequently may be affecting the two important endocrine systems involving in the extrapulmonaries are adrenal, that is Addison's disease, and bone and joints, and pericardium, and pleura, and tuberculous. The tuberculous involvement in the CNS, that is may lead to the endocrine manifestations like SIDH or diabetes insipidus. So the most common extrapulmonary are lymphatic, and subsequently may be a meninges, genitourinary, or bone or pleura. And so these are the various endocrine systems. So the most common system affected by tuberculosis are adrenals, and subsequently maybe a brain, hypothalamus or pituitary, and thyroid are very rare, and similarly gonads, ovary and testes also very rare to involve, and pancreas also similarly. That's the first and most is adrenal, and subsequently maybe a pituitary or hypothalamus, then maybe last at ovary or thyroids or other thing. So before going to the details, there are various immune alterations are happening subsequent to infections to the tuberculosis. So it predominantly affecting the cell-mediated immunity, and as a result of tuberculous infections, there are various cytokines being released into the system. That is a predominant one is interleukin 6 and gamma interferon. And subsequently, these cytokines has various impact over the various endocrine systems like hypothalamus, pituitary, as well as the thyroid. And as a counter-regulatory mechanisms, there are increased release of cortisol. So whenever tuberculosis is affecting the adrenal, there may be a defect or release, delay in the release of cortisol or adrenal insufficiency. So as a normal phenomena, there should be a good immunity if it is happening, then adequate cortisol reserve should be there. And that is a normal response. And subsequently, it increases the helper T2 cells and improve the immunity. And subsequently, by thyroid, it increases the T4 and T3 and leading to the catabolic state, that is a hypercatabolism. So thin, lean, emaciated, all the symptoms of tuberculosis happening in the body. So coming to the one by one, I will enumerate the involvement of tuberculosis. The first and foremost is adrenal involvement. So this is the most commonly involved endocrine organ in tuberculosis, and predominantly the mode of spread are hematogenous. And adrenal involvement is seen in around 6% from around 6 to 10% from various studies in patients with active tuberculosis. And many of the times, almost more than 90% adrenocortical functions may be normal, even though there may be involvement of adrenal. So for adrenal insufficiency to develop, almost 90% of the gland to be destroyed before the insufficiency happens. So that if patients presented with the adrenal insufficiency features, almost there should be a 90% destruction in the adrenal, both the medulla as well as the cortex. Then only there may be a features of adrenal insufficiency. And simple clinical clues or hyperpigmentations may be the palmar aspect as well as oral mucosa. So the reason is the high ACTH. So ACTH acts through the melanocyte stimulating hormone and leads to the hyperpigmentations from the various body. And various investigations we can do at presentations whenever we suspect adrenal insufficiency are cortisol, ACTH, electrolytes, and whenever the cortisol is borderline, then we can do for ACTH stimulation test. And I will be discussing in later. And coming to the imaging, there can be two things happen maybe in imaging. In active or recent infections, usually there may be a enlargement of the adrenal. So you can see that right end of the slides, you can see the bilateral adrenal involvement. So one of the common differential diagnoses are any granulomatous infections or malignancies or lymphoma, there may be a bilateral adrenal enlargement. So one of the reason for bilateral adrenal enlargement is tuberculosis. And in later stage, there may be a calcification. So you can see that bilateral adrenal calcification. So one of the classical features of tuberculosis, but it is a very, very late or last stage of tuberculosis whenever the patients develop adrenal calcification. So many of the times there may be a primary adrenal insufficiency in such type of individual. So in early stage, there may be adrenal enlargement. At very late stage or inactive stage, there may be a calcification and atrophy of the adrenals. So we have to be, and whenever patients presented with adrenal insufficiency, today morning also you have heard talk regarding the adrenal insufficiency critical illness. So this is regarding the adrenal insufficiency tuberculosis. So whenever there is a clinical suspicion is there, as already the previous speaker pointed out, before giving any steroids, you take the sample for serum cortisol. And serum cortisol, if less than 2 microgram, then it is a more confirmative. So 2 to 5 is a borderline, and more than 5 or more than 10, it is a definite that is a normal cortisol response. So in a borderline category, you go for coast-introphin stimulation test. And before that, you can do ACTH also and electrolytes. So the ACTH is very high in presence of tuberculosis backup. Then the most common is tuberculosis involvement in the adrenal. And so we have to treat with glucocorticoids or mineralocorticoids. And usually in overt adrenal insufficiency, ATD doesn't appear to restore the function. So we have to treat both the conditions whenever we suspect adrenal involvement in tuberculosis. One end we have to give ATT, another end we have to give steroids. So one of the indication of steroid in tuberculosis, apart from the meningeal TB or pleural or pericardial TB, and so one of the indication for giving steroid in tuberculosis is adrenal involvement. And we have to keep it in mind that rifampicin is one of the potent enzyme inducers, and it will accelerate the metabolism of steroid. So we may require increased steroid dose to prevent the adrenal crisis. And this is the regimens we can give depend upon the body weight, hydrocortisone as well as the fludrocortisone, because the adrenal cortex as well as the medulla both are destroyed by the tuberculosis. So we have to give always the mineralocorticoid support, maybe initially at 100 microgram per day, and later we can reduce the fludrocortisone dose once the patients are clinically stable. And hydrocortisone we can give as a splitter dose 2 times or 3 times per day. Prednisolone if you are starting, then we can give once daily is enough. And DHEAs may be useful for adrenal androgens, particularly in female individuals. And coming to the pituitary tuberculosis, and from various studies, the prevalence of pituitary tuberculosis is almost around 1 to 4% among the intracranial TB. So the TB can affect any part of the CNS, and the pituitary involvement is around 4% of tuberculosis involvement of the brain. And route of spread may be a hematogenous or from the local extension from the sphenoid sinus, brain or meninges. And the most common symptoms depend upon the involvement of the pituitary. So the most common involvement is hormone abnormalities or hyperprolactinemia, maybe early in females like secondary amenorrheas or galactorrhea or infertility. So the male will present with later this hyperprolactinemia symptoms. And there may be a cortisol insufficiency or there may be a central hypothyroidism. So we have to be closely read the reports of T4 or free T4. We should not go by the TSH value alone whenever we suspect central hypothyroidisms. And there may be a multiple pituitary hormone deficiency like gonads, cortisol as well as the thyroid. And so depend upon the symptoms, depend upon the hormone or pituitary cell involvement, we can have varieties of symptoms. And so this is one of the pictures of involvement of the tuberculosis in pituitary. You can see that thickening of the stalk. So we need dedicated cuts or pituitary cuts for defining these type of lesions. So you can see that this is the pituitary stalk, and both side the internal carotid is there, and the contrast, and that is hyperintensity in the pituitary tract. So this is a classical features of pituitary involvement or hypophysitis, that is inflammation of the hypophysis or pituitary tract. So many of the times these patients may present with polyuria or diabetes insipidus features, and always we have to, for confirmations, we need a tissue sample for tuberculosis confirmations. The transspinal route may be a biopsy to possible, and we have to treat both simultaneously with the anti-tuberculosis therapy as well as the hormone replacement according to the symptoms of hypopituitarism. And one of the common manifestations of tuberculosis in brain is a SIADH or syndrome of inappropriate ADH secretions. And it can see up to 60% of the TB meningitis, and pulmonary tuberculosis also may lead to the pictures of SIADH. And diabetes insipidus can happen whenever there's involvement of the pituitary stalk or involvement as a part of hypopituitarism, panhypopituitarism. It is more common with children comparing with the adult. And moving on to the tuberculosis of thyroid, even though the thyroid disorders are very common, but tuberculous thyroid is very, very rare. And even if I have seen my 8 years post-DM experience, only one case of tuberculous thyroid. So it is very rare to pick up the tuberculosis of thyroid, and symptoms are very variable and non-specific, and many of the times thyroid functions may be normal. So whenever we are evaluating for thyroid nodule, we may pick up the tuberculosis, and there are various manifestations of tuberculous thyroid are solitary nodule, maybe a diffuse goiter or acute abscess or multiple lesions or chronic fibrosing tuberculosis. Because why tuberculosis is rare or rarely affecting the thyroid is because of the colloid nature of the thyroid. It has bactericidal actions and presence of the tight thyroid capsules and presence of iodine. So these are all the things, the nature's counterproductive mechanisms to prevent the thyroid development of tuberculosis. So for definitive diagnosis, we need histopathological examinations and positive staining, and maybe a positive culture. So we have to wait for almost 6 weeks and response to the anti-tuberculosis therapy. And moving on to the tuberculosis and calcium metabolism, so the prevalence is around 2 to 20% from the various studies. So what is happening is the alveolar macrophages express more and more 25 hydroxylations. So ultimately it leads to production of the 125, that is active vitamin D or the calcitriol, what we commonly available. So the more and more productions of hypercalcemia by 25 hydroxylase activity level, it lead to the active vitamin D, and it is less frequently noted in extrapulmonary. So the more common with hypercalcemias are pulmonary tuberculosis. And another one more mechanisms are the toll-like receptor activations of macrophages, and it leads to the vitamin D expressions are more. And classically the lab findings are suppressed PTH. So it is a PTH independent hypercalcemia and very high level of 125 dihydroxyvitamin D. Usually the vitamin D level, that is a classical vitamin D, 25 hydroxy will be normal in the granulomatous tuberculosis related hypercalcemia. So this is the picture here. The more and more 25 hydroxylations are activating or synthesizing from the macrophages, and it leads to very high 125 dihydroxyvitamin D. So what is the clinical implications? So routinely we used to supplement vitamin D in many of the situations. So always you do calcium level before starting vitamin D or calcium in tuberculosis individuals. Even though theoretically the ketoconazole may be one of the drugs may be useful for 25 hydroxylation, but practical implications may be very less. And coming to the tuberculosis of reproductive endocrine systems. So the tuberculosis of female genital tract, the ovaries are less commonly affected. The most common systems are reproductive is in female is a fallopian tubes, and ovary very rarely affected. And many of the times very, very difficult to pick up the tuberculosis or ovary. Many of the times gynecologists will operate the ovary in suspicious of malignancy. Surprisingly, histopathology will come as a tuberculosis by cacheations or granulomatous or positive staining. And so always tuberculosis of ovary, it's a very late or post-mortem diagnosis rather than suspicious in the pre-operative itself. And the male genital tract, the most common site are epididymis, prostate, and subsequently the last one is affected is the testis. So whenever the testis involvement is there, there may be always epididymoarchitis. And in clinically we can see the scrotal mass in acute infection is there. Otherwise beaded or irregular or nodule epididymis, it's maybe a thing. So only concern for the tuberculosis of ovary and testis is the infertility. So many of the times these tuberculosis infections which leads to the decrease in sperm count, and as well as the quality of motile sperms also will be reduced, and blockage of the vas or subsequently secondary atrophy. So the infertility is the thing of tuberculosis. And last is tuberculosis and pancreas. Again, the pancreas tuberculosis is a very rare, and it's diagnosed as very late or post-operatively or histopathological examination when analyzed. It is being diagnosed more commonly, and most case diagnosed at laparotomy performed for a suspicion of malignancy. And one important investigations we can do to avoid surgery is endoscopic ultrasound. So we can take biopsy through the endoscopic ultrasound, and always useful in insulinoma in endocrinology, this endoscopic ultrasound. So this is a patient's look like malignancy mass over the pancreas, head of the pancreas, and subsequently this patient was diagnosed as a tuberculosis. And so uncontrolled diabetes is a risk factor for active tuberculosis, and tuberculosis infection itself can worsen the glycemic control, and it also associated with the worse outcome of tuberculosis. And drug-drug interactions, we have to keep it in mind. So I am not going to the diagnostic of tuberculosis, and so we always prove tuberculosis by either one of the methods, sputum or cultures, or now recent the BACTEC or PCR method, or gene expect also available. We can get the report very fastly. And the tuberculosis the ATT can affect various endocrine systems like thyroid and adrenals. It precipitates the metabolisms like rifampicins, and failure of oral contraceptives in gonads, and calcium metabolism. And so this is the last one, the endocrine abnormalities in tuberculosis. So I already highlighted the most common is the adrenal, and subsequently the pituitary, and later maybe a pancreas or testes or ovary. By metabolism aspect, when we concern is a hyponatremia or a syndrome of inappropriate ADH secretions, and the hypercortisolisms can happen whenever the reserve is good. And coming to the summary, so the endocrine and metabolic manifestations of tuberculosis are very unique, and it may be a direct involvement of endocrine by hematogenous spread, or indirect effect of the infections, and the impact of treatment on hormonal functions to be considered. And it can affect any endocrine systems like pituitary, adrenal, and thyroid, and most is the adrenal gland. And tuberculosis of thyroid is very rarely reported, and isolated ovarian TB and male genital TBs are rare, and always keep it in mind that it is a last diagnosis, and treatment plan should be tailored to take into the account both the direct as well as the indirect impact of Mycobacterium tuberculosis. So with that I am concluding. Thank you for your kind attention.
Thank you so much, sir, for such an enlightening speech.